Bismillahirrahmanirrahim. Thank you very much, Dr. Abdussalam and chairpersons and colleagues. My talk is about the management of hypertrophic cardiomyopathy, and we know that hypertrophic cardiomyopathy is a relatively common congenital heart disease because of its autosomal dominant trait, and a lot of patients they are there and they are symptomatic, and treatment whichsoever is available is in the form of symptomatic relief by beta blockers or other antiarrhythmics and like that, but nothing is going to change the real face of the disease. Even surgical myomectomy or alcohol ablation, these are the procedures which are really very high tech, and this medicine has come recently, and we are going to go into the details of this, how a medicine can change the face of the disease. So we all know that it's hypertrophic cardiomyopathy is an abnormal muscles because of the genetic predisposition. And the guidelines of this, the patients with hypertrophic cardiomyopathy, either they are treated with, to relieve the symptoms, they are either treated with beta blockers or other antiarrhythmics. And the gradient, if it does not change otherwise, the beta blockers, they are going to slow down, and this is how they affect the gradient, but otherwise it's not changing the disease. And if the person, then septal ablation and all those, these are the techniques which are used to remove the gradient across the left ventricular outflow tract. And this medicine, which we are going to discuss in few slides, is a first-in-class selective cardiac myosin inhibitor, and it has been approved in symptomatic obstructive hypertrophic cardiomyopathy. Is indicated for the treatment of adults with symptomatic NYHA class 2 and 3 and who have obstructive gradient as well. So for patients with obstructive hypertrophic cardiomyopathy who have persistent symptoms attributed to left ventricular outflow tract obstruction despite beta blockers or non-dihydropyridine calcium channel blockers, then this medicine is recommended so far, and it's class 1B indication, and it is in the European Society of Cardiology guidelines, and it is in American Heart Association guidelines as well. So mechanism, it reduces the number of myosin heads that can bind with actin, and thus normalizing the probability of force producing systolic and diastolic cross-bridge formation. So it reduces excessive contractility and dynamic left ventricular outflow tract obstruction, improves myocardial energetics and cardiac filling pressure in patients with hypertrophic cardiomyopathy. So this is, by doing this actually, it reduces the left ventricular outflow tract obstruction, normalizes diastolic function and quality of life and physical functioning. These are the trials which have been done from 2016 to 24, and most of them, they showed better results. We will be talking about one or two trials. The Explorer HCM trial, a phase 3 randomized double-blind placebo-controlled 30-week trial with more than 3,000 patients with hypertrophic cardiomyopathy and LVOT gradient of more than 50 millimeter and NYHA class 2 and 3. So these patients, they got benefit in terms of the gradient reduction as well as the oxygen consumption and NYHA class as well. You can see that 37% in the drug and the other placebo only 17%. So it's significantly reduced LVOT obstruction, means in change in post-exercise LVOT gradient, peak gradient, and you can see that this is on baseline at 30 weeks and how it is giving benefit. And this is a Weller HCM trial, long-term efficacy and safety of the drug, mavactam, which were treated with this in the previous trial, and then they were continued with the long-term use, and there was 82% benefit of this. and the patient, they needed less surgical intervention or non-surgical intervention. So with mavacamten, significantly more patients improved by NYHA class, which was 63% of patients, they became NYHA class 1. And this is another study which also showed that this is a long-term study of more than 250 weeks and of treatment, and the benefit was there. So this is functional class improvement shown in this trial, long-term trial, and it is there in base 12 weeks, 48 weeks, and all those. And improved in class, some patients, they improved from class 3 to class 2, and some patients from class 2 to 1, and only few patients, they worsened, and why they worsened, we will be discussing it in little bit detail. So adverse effects are syncope and dizziness and heart failure. If this drug needs to be monitored by doing echocardiography, because it not only reduces the ventricular outflow tract obstruction, but may cause damage to the ventricle and reduce ejection fraction as well. And because its metabolism is through the cytochrome P450 system, and we know that the patients with different, they have different kind of cytochrome systems, so that some patients, they will need more drug, and some patients will need less drug, and some patients will be having more side effects and less side effects depending upon this. So it is rapidly absorbed biphasic elimination profile, and in different cytochrome systems, actually it is, if they are normal metabolizer or poor metabolizer, so its half-life will change. And so this is how it has started, initially 5 milligram once daily, and then after 4 weeks, depending upon whether the gradient has reduced or not, and we can increase the medicine and can continue it. And if the ejection fraction drops less than 50%, then the drug is stopped, whether it is temporary stopping or it is a little longer time. So maintenance dose, it has been in different doses, even 2.5, 5, 10, 20 milligram, depending upon patients and their follow-up results on echo. So conclusion, it's a first novel therapy for HCM, effective and reversible myocardial relief, reduced need for surgery in high-risk HCM patients, improved NYHA class and exercise capacity, requires careful monitoring, integrated into updated guidelines. Thank you very much.